Chapter 5 will cover the understanding of athletic injury terminology and classification. Athletic training is a multidisciplinary profession that requires significant interprofessional interactions in the provision of patient care. The ability to communicate with other medical professionals is an essential professional skill. This level of communication begins with the development of a professional vocabulary. In addition, athletic training students in a professional program must create a framework that allows them to understand injuries and medical conditions. The athletic trainer must be able to communicate effectively, both orally and in writing. To be a health professional dedicated to interprofessional, patient-centered care means to be joined and aligned with other health professions in the interest of doing what is best for the whole patient. To do so, a common ground must exist for proper communication. This common ground includes the nomenclature we use to discuss injuries and medical conditions, as well as the symbols, abbreviations, and common language we use to document medical records. It is also important that understanding athletic injuries begins with a basic understanding of anatomical structures, such as bone, muscle, tendon, ligament, cartilage, nerve, vascular tissue, and the specific organs that are subject to injury. Myositis, osteoarthritis, and avascular are all examples of medical terms. The best strategy to understand these words is to break the words into specific parts in order to understand medical terms and use them appropriately. Most medical words are composed of specific word parts, most often with Greek or Latin origins. The word parts may sometimes be connected by vowels to create the complete medical term. A prefix is the word part that appears before the word root, while the suffix appears after the root. The documentation of patients' medical information is an important job responsibility for any healthcare professional. Common examples of documentation in athletic training include evaluation of injuries and illnesses, treatment plans and patient goals, rehabilitation progress, physician visits, and discharge from care. These forms of documentation are a medical legal responsibility of the professional athletic trainer. Proper documentation allows a patient's care to be recorded accurately and to protect the sports medicine team from claims of negligent care. Documentation allows the athletic training professional to keep appropriate paperwork and have recorded information that allows proper communication with physicians, other athletic trainers, and other healthcare providers. One of the most common documentation techniques is a SOAP note. SOAP stands for Subjective, Objective, Assessment, and Plan, respectively. It is an acronym that allows you to keep different types of information separate. Subjective information is usually what is told to you by the patient and includes a history and any information relating to his or her chief concern for reason for seeking care. Objective information can be observed or measured and includes findings from your physical examination of the patient. The assessment is the diagnosis or impression of the injury or illness. The P in SOAP stands for plan. The plan is what you will do next, and there are many possibilities. The plan might require an immediate referral to a physician's care or the care as a part of a larger rehabilitation effort. Table 5-2 on page 92 are examples of common abbreviations and symbols that are used when writing SOAP notes and are universal across health professions. Currently, one of the most common forms of documentation is the electronic medical record, or EMR. The implementation of EMR may limit the need for written evaluations and abbreviations. However, the implementation in some athletic training settings, such as secondary schools, has been slow. The use of EMRs will soon be ubiquitous as healthcare facilities come into full compliance with the Health Insurance Portability and Accountability Act, or HIPAA, rules and guidelines that allow for secure and easy sharing of patients' records among providers. An EMR contains the standard medical and clinical data gathered in one location by a healthcare provider. EMRs are more beneficial than paper records because they allow providers to track data over time, identify patients who are due for preventative visits and screenings, and monitor how patients measure up to certain parameters and provide a repository for baseline data. Examples for this are concussion testing and laboratory tests. The EMR differs from an electronic health record, or EHR, in that EHRs go beyond the basic data collection and include more comprehensive patient history. Discussing injuries with patients and lay people can lead to the use of terms that are not benefiting of a student wishing to become a healthcare professional. As an athletic training student, it is important to dismiss inappropriate injury terminology as soon as possible, the worst of which seems to come from sportscasters and color commentators. From this point forward, you will no longer accept terms like tweaked, pulled, cranked, and dinged when discussing injuries and medical conditions. Improper terminology minimizes the seriousness of sport injuries and can lead to misconceptions. Students who use terms properly will have an advantage when communicating with faculty, clinical preceptors, and other healthcare professionals they encounter in their professional preparation program. The next section of this chapter presents terms and definitions specific to athletic injuries that sometimes lead to confusion and are frequently misused by the lay public. This list can serve as a starting point for understanding the language of injury and developing good habits for the proper use of terminology. A sprain is an injury to a joint, which most involves injury to a ligament and/or the joint capsule. A strain is an injury to a muscular tissue or the muscle tendon complex. To understand the grading of severity of these types of injuries, please review the box on page 99. An acute injury is a recent injury that presents with a rapid onset. An acute injury may also refer to an injury that is in the early stages of inflammation. A chronic injury is defined by its slow onset and long duration. An example of acute injury is an ankle sprain, and an example of a chronic injury is tendinitis or inflammation of a tendon. A dislocation is the complete disarticulation or separation of a joint. A subluxation is a partial or incomplete dislocation followed by an immediate and spontaneous relocation. A sign is something that the athletic trainer can observe or measure, while a symptom is something the patient describes to you. For example, I observe my patient has a pale appearance, which is a sign, and she describes that she has no appetite, which is a symptom. A syndrome is a collection of symptoms. Patellofemoral pain is often described as a pain syndrome characterized by several signs and symptoms, such as a mobile iliotibial band tissue, poor ankle motion, and weak quadriceps. The three suffixes of osis, algia, and itis can lead to some confusion to the athletic training student. Osis means condition of, algia is a generic reference for pain, and itis is the most common of the three and means inflammation of. When evaluating musculoskeletal injuries, discovering swelling in joints and the surrounding tissues is commonplace. The type and location of swelling dictates what it's called. Edema is swelling that results when fluid collects in connective tissue. An effusion is a collection of fluid contained within a joint space or joint capsule. Ecchymosis refers to the discoloration that often accompanies edema. Bruising is a form of ecchymosis. Another common source of confusion surrounding muscle actions is the difference between concentric and eccentric muscle contractions. A concentric muscle contraction occurs when a muscle shortens and there is movement at the joint. An eccentric muscle contraction is when a muscle is lengthening against resistance. Eccentric contractions have greater association with musculotendinous injury and delayed onset muscle soreness, or DOMS. The athletic training student who masters the language of movement and body position will have a solid foundation for understanding injury and better utilizing his or her knowledge of anatomy. Any discussion of movement and body position should begin with knowing the anatomical reference position. Figure 5-1 illustrates the anatomical position. To stand in anatomical position is to stand erect with your feet shoulder-width apart and your arms hanging relaxed at your sides, palms facing forward. The following terms describe the relationship of specific body parts to other parts of the body or objects external to the body. The following are common terms with which students should become familiar with. Superior or cranial, which is closer to or towards the head. Inferior or caudal, which is further away from or toward the feet. Anterior or ventral, which is toward the front of the body. Posterior or dorsal, which is toward the back of the body. Medial is toward the midline of the body. Lateral is moving away from the midline of the body. Proximal is closer to the trunk. Distal is away from the trunk. Superficial is toward the surface, and deep is inside the body, away from the surface. The body is divided into three cardinal planes that bisect it in 3 dimensions. The cardinal planes are reference points that can be thought of as imaginary flat surfaces. The 3 planes are sagittal, frontal, and transverse. These planes are referenced in figure 5-2 on page 95. The movements that occur in these planes are found on table 5-3 on page 96. Injuries can be classified based on several characteristics. Did the injury occur rapidly or gradually? Is the injury life-threatening or of a lesser severity? Did the injury cause the patient to miss any of his or her normal physical activities? The answers to these questions help shed light on how athletic injuries are classified. As previously mentioned, injuries can be classified as acute or chronic. An acute injury has a rapid onset, while a chronic injury is an injury that progresses over time and has a slow onset. The body responds to injury by activating an inflammatory process. This process is a series of physical, chemical, and vascular events. Healing injuries will progress from acute inflammation to the stages of repair and remodeling. The athletic trainer must be able to determine when an injury is in the acute stage based on the signs and symptoms of inflammation, not just the time elapsed since the injury occurred. Knowing the stage of injury healing is essential to proper management and will assist in selecting proper course of treatment. How an injury occurs is also called a mechanism of injury, or MOI. Compression, shear, and tension are all mechanical forces that can contribute to injury. Compression occurs when tissues absorb force, shear occurs when tissues are pulled in opposite directions in relation to one another or on a perpendicular axis, and tension occurs when tissues are pulled in opposite directions, such as a stretching motion. Understanding the MOI is essential information in the injury evaluation process and is helpful to the athletic trainer as he or she makes appropriate referral or treatment plans for the patient. Injury surveillance is an essential tool in determining the scope of athletic injuries under a variety of conditions. Injury surveillance studies gather data to better understand the rate, type, and severity of injuries under specific conditions for a given sport or activity. Such studies can yield valuable information that can assist with rule modifications such as safety precautions, examination of equipment and participation of conditions, and appropriate staff decisions. An example of the data that comes from doing injury surveillance is that most catastrophic injuries at the high school and college level are in the sport of football. The definition of injury by type, whether it's acute or chronic, only gives us information in very general terms. To learn more about specific injuries and how they are classified, we need to examine the type of tissues involved. A fracture is a disruption in the continuity of bone. Fractures are described as being either open or closed depending on the integrity of the skin. An open fracture is one that is sometimes referred to as a compound fracture. However, this term can be confusing and has fallen out of favor. For a list of the different types of fractures and their descriptions, please see Figure 5-9 on page 102 in the textbook. One specific type of fracture, an epiphyseal or growth plate fracture, has different classifications based on the Salter-Harris classification. These are also shown on Figure 5-10 on page 103. A chronic injury that occurs to bone is referred to as a stress fracture. This type of fracture is common to the tibia, metatarsals, femoral neck, and tarsal navicular in the foot. This fracture occurs as a result of an imbalance between bone production and bone loss. Stress fractures often develop when there is a change in the volume of physical activity, the intensity of the physical activity, a change in footwear, or a change in the playing surface. Correcting biomechanical deficiencies and making appropriate adjustments to activity are key treatment considerations. An injury causing tearing to the fibers of a muscle is called a strain. Strain injuries are graded from 1st through 3rd degrees based on the amount of damage to the tissue. Muscle strain injuries are caused by overstretching of the muscle or an overload to the tissue caused when the muscle must absorb forces while still under tension. Muscle is a unique tissue that has the ability to both contract and be stretched. It is elastic and can be adapted over time. Sitting for an extended period of time and having tightness in your hamstrings when you get up are examples of how rapidly muscles can adapt. Maintaining flexibility and properly warming up the muscle tissue prior to activity are keys to preventing injury. Any discussion of muscle injury must also include injuries to the tendons. Tendons attach muscle to bone, and the location where muscle and tendon come together is called the muscle-tendon junction. The muscle-tendon junction is a common site of a strain injury. Tendons are strong connective tissue comprised of collagen. They differ from muscle tissue in that they do not have a contractile element. Injuries to the tendon itself may be either acute or chronic. There can be significant confusion on the terms surrounding tendon injury. Students and clinicians must know the difference between tendinitis, tendinosis, tendinopathy, and tenosynovitis. Tendinitis is the inflammation of the tendon, which results from micro tears that happen when the musculotendinous unit is actively overloaded with a tensile force that is too heavy and/or too sudden. Tendinosis is the degeneration of the tendon's collagen in response to chronic overuse, when overuse is continued without giving the tendon time to rest and heal. Tendinopathy, typically used to describe any problem involving a tendon. While most experts define tendinopathy as an umbrella term to describe all tendon conditions, others may use it to describe a chronic tendon condition that fails to heal. Tenosynovitis is the inflammation of the fluid-filled sheath called synovium that surrounds the tendon. The final tendon injury is a tendon rupture. Acute tendon ruptures are less common than overuse injuries, but they can occur in physically active populations. A contusion is another soft tissue injury that most often affects muscle tissue. A contusion is a closed injury caused by a direct blow that compresses the underlying tissue. While often a minor injury, an improperly managed contusion can lead to myositis ossificans, which is a calcification or abnormal bone growth that can occur within the muscle tissue over time. Injuries to joints represent some of the most common conditions the athletic trainer will encounter. A joint or articulation is a point where two bones join. Acute injuries can occur to synovial joints when forces cause the ligaments or capsule to extend beyond their limits. An injury to the ligament or the capsular tissue of a joint is called a sprain. Like muscle strains, a sprain is graded in degrees of severity, first to third. If the articulation is forced beyond its anatomical limits of motion, it may either sublux or dislocate. When an articulation dislocates for the first time, the athletic trainer must have the joint evaluated for a possible fracture. To relocate or reduce the joint, only trained licensed medical professionals should attempt this procedure, as it could cause further damage to the surrounding tissue. Chronic injuries are most often caused by repetitive trauma, overuse, changes in workload or volume, and biomechanical insufficiencies. One category of chronic injury is osteochondrosis, or degenerative changes to the ossification centers of the bone. Osteochondritis dissecans is an inflammatory condition that can include a loose body or fragment in the joint. Patients with degenerative or inflammatory changes to the articular surfaces are said to have osteoarthritis. An inflammation of the synovial capsule that surrounds the joint is called synovitis. Chronic soft tissue inflammation can also occur in the bursa. A bursa is a fluid-filled sac or potential space that is found in areas of increased friction at synovial joints, between tendons and bones, at locations of bony prominences, and near tendons and ligaments. The suffix itis indicates that bursitis is an inflammation of the bursa. Bursitis is caused by repetitive trauma, overuse, and biomechanical insufficiencies. Normal musculoskeletal function relies on input from sensory nerves to our central nervous system and output by our motor nerves to the periphery. This constant flow of information controls our ability to perceive pain, have motor reactions, maintain smooth motor reactions, maintain smooth motor movements, and have awareness of our surroundings. Within the context of athletic injuries, nerve injuries are most often secondary injuries associated with another primary injury. Fractures or dislocations may cause compression to nerves when bones are forced into improper positions. Nerves can be stretched or compressed by direct changes in body position or direct blows. Burning pain, radiating pain, and numbness are often associated with nerve injuries. Neuritis is an inflammation of a particular nerve and is associated with nerve entrapment. A stretch injury causing paresthesia and weakness is called a neuropraxia. Compartment syndromes are injuries to the vascular and nerve tissue due to increased pressure in the extremities. Acute compartment syndrome are a result of swelling and pressure secondary to a traumatic event. If left unattended, an acute compartment syndrome may lead to tissue death. A subacute compartment syndrome can sometimes present following prolonged exercise. These syndromes are characterized by increasing pain, loss of function due to compression of nerves, and compromise of blood flow due to compression of the vascular tissues. Medical terminology provides a common language for the athletic trainer to communicate with other healthcare professionals on behalf of our patients. The athletic training student who develops a working vocabulary and understands common word parts will be better equipped to complete class readings, interpret journal articles, and communicate in an effective professional manner. Taking the time to develop these skills early can pay great rewards in the future. Understanding injury begins with knowing the types of injuries that can occur and how each specific tissues are affected. Learning how tissues respond under acute and chronic conditions allows the athletic trainer to make appropriate referral and management decisions. Knowing the various types of injuries, what tissues are affected, and how injuries are classified is a common starting point for all athletic training students.